Good morning. So today we're going to start talking about lifespan development, and then we will go on into uh, childbirth and geriatrics, and then into special considerations and populations. My name is Jessica Hertzler, and we will start this session with lifespan development. In our lifespan, we start with neonate. This is going to take you through the different age groups. Neonate is considered birth to 1 month of age, and from 1 month to 1 year of age, we're looking at the infant. Okay? Things I want you guys to keep in mind is that in infancy, their airway is a little bit different than that of the adult. It is shorter. It is more narrow, therefore it is more likely to be obstructed. The next age group is the toddler group. The toddler group is from the age of 1 to 2 years old up to their 3rd birthday. Preschoolers range in ages from 3 years old to 5 years old. From the preschool group, we move on into the school age, which is 6 to 11 years old. And then one of my favorite, being sarcastic here, is the adolescent group, ages from 12 years old to 15 years old. After adolescence, which can be a trying time, as we all know, we move on into early adulthood, which are the 20 to 40-year-olds. Then our middle adulthood, which is 41 to 60 years old. And then, of course, our late adulthood, which is 61 years and older. Now, your book goes into the physiological and sociological changes and challenges that each age group goes through. And so you need to review those in preparation for your exams and to better understand some of the challenges these different age groups meet. Okay, that was pretty quick. Let's move on to obstetrics and neonate care. This one takes a little bit longer. So when we talk about obstetrics, we know that the female has 2 ovaries. These are considered to be gonads. These 2 ovaries are usually on each side of the uterus in the upper pelvic cavity. These organs secrete estrogen and progesterone. Estrogen and progesterone prepare the uterus for implantation of the ovum. The ovum is the mature egg. The mature egg, or the ovum, moves down into the fallopian tube, and this is typically where fertilization occurs. And it occurs in approximately the distal third of that fallopian tube. Through peristalsis, this ovum is projected through or moved through the fallopian tubes down into the uterus, where it will attach to the uterine wall. From the point of attachment until expulsion of the baby, the uterus is going to be the housing component of the fetus and baby or baby. The uterus is a pear-shaped organ that actually holds or houses the mature ovum all the way to expulsion of the baby. The top of the uterus is called the fundus. You need to know that. And the bottom of the uterus, where it begins to narrow and taper into a neck-shaped, that's a bad way to put it. It becomes more narrow at the inferior portion of the uterus is called the cervix. The cervix connects the vagina and contains the mucus plug. Now, this mucus plug is pretty important. The mucus plug is what seals the cervix protecting the baby inside of the uterus. It protects the baby from contaminants and loss of the amniotic fluid. As mama progresses through her pregnancy and prepares for delivery, the cervix will become thinner and will begin to open up, if you will, or dilate. And this allows for the mucus plug to be expelled. This expulsion of the mucus plug is sometimes known as a bloody show. That bloody show signals the first stage of labor. The placenta, very important, also known as the afterbirth. The placenta is attached to the uterine wall. The placenta is the organ that allows the baby to receive oxygen and nutrients from the mom through the umbilical cord. It also allows for the excretion of waste, such as carbon dioxide. It's important for us to know that the blood of the fetus and the mom do not mix except during birth or miscarriage. And this is all because of the placenta and the umbilical cord. Now, after mom delivers the baby is expelled from her body. The placenta will separate from the uterine wall. And if we are presented with the placenta, if we would happen to conduct a childbirth in the field, it is imperative for us to bag and bring that placenta with us to the hospital, where they will further inspect and weigh it. The umbilical cord, which is the infant's lifeline between connecting mom to the baby by means of the placenta, is usually about 22 inches long, and it contains one vein and two arteries. The vein carries oxygen-rich blood and nutrients to the fetus, where the arteries will carry deoxygenated blood and waste products back to the placenta, where mom will be able to excrete those from her body. The amniotic sac, which houses the baby as well inside the uterus, contains amniotic fluid. This allows the baby to be protected and insulated, and it kind of acts as a shock absorber as well. Baby is very well protected while mom is pregnant because of course, mom's musculature and the uterus, but also because of the amniotic fluid. The fluid amount varies from about 500 to 1,000 milliliters per pregnancy. And if mom tells you my water broke, usually what's happening is she's progressing through the delivery stages and her amniotic sac has torn. Okay. She may think she urinated on herself. And it may not be a gush of this fluid. It may simply be a trickle or a steady flow. Nonetheless, if she tells you, I think my water broke, you as a competent and knowledgeable EMT should recognize that as imminent delivery. The lower part of the birth canal is known as the vagina, and it originates at the cervix and extends through the external opening of the body. The smooth muscle layer of the vagina allows it to stretch gently and accommodates for the passing of the infant during delivery. The cervix, let's go back to the cervix, it will dilate to approximately 10 centimeters, allowing the baby to pass through the birth canal, out of the cervix and out of the external vagina. Pregnancy is divided into 3-month periods, three-month periods, equaling a 9-month duration or 40 weeks. Those 3 months are divided by what's known as trimesters. The first trimester is months 1 to 3 or weeks 1 to 12. Our second trimester is from months 4 to 6 or weeks 13 to 27. The third trimester is months 7 to 9 or weeks 28 to 40. A couple of words you need to be familiar with is gravida and para. Gravida is the how many times the patient has been pregnant, regardless of miscarriages or abortions, or those two things. The how many times the patient has been pregnant is known as gravida. Para is how many births she has encountered. How many children has she delivered? Okay, so if she had a stillbirth or if she had multiples in one pregnancy, you would count those individually when you are recording para. So if she is gravida 2, para 1, that tells me she's been pregnant twice and has given birth to one baby. If she is gravida 3, para 4, it tells me she's been pregnant 3 times, and she has delivered 4 children. Okay? Next, we're going to get into some of the antepartum emergencies, such as spontaneous abortion, also known as miscarriage. This is the delivery of the fetus and the placenta before the 12th week of gestation. Okay, she's still in her first trimester, and her body goes into labor, and she delivers the fetus. This occurs before the 12th week of pregnancy. 80% of miscarriages occur in the first trimester. And it's usually caused because of a genetic or uterine abnormality, maybe infection, drugs, or maternal disease. Signs and symptoms of your spontaneous abortion: mom will tell you that she's cramping. Okay, these cramps can be mild to severe, and she will have moderate vaginal bleeding, and that blood may be dark red or bright red. And she will begin passing tissue or clots. Okay. An elective abortion is different from a spontaneous abortion. An elective abortion is the termination of pregnancy upon request of the mother in a medical setting. It's important for you to know the differences. Spontaneous, the body rejects the baby for whatever reason, and elective is the mother's choice. Now, in either situation, your treatment is basically going to consist of emotional support. If mom is showing signs or symptoms of hypovolemic shock, because there may be severe bleeding, it's imperative for us to manage the signs and symptoms of shock. And we know we're going to do so by placing her with her feet elevated, covering her with a blanket, and possibly placing her on oxygen. Ectopic pregnancy is a very common occurrence. It's, your book tells you it's a rare occurrence, happening in about 20 per 1,000 pregnancies. I guess I said it was common because I've seen it so often in the field. So what happens with the ectopic pregnancy? The egg, the mature ovum, is implanted outside of the uterus. It's going to either be in the fallopian tube, which happens approximately 90% of the time, but sometimes it can attach itself to the abdominal peritoneum, okay, or the covering on the outside of the uterine wall. It can attach itself on an ovary or even on the cervix. What happens is that the placenta eventually evades the surrounding tissue as it grows, as the ovum and the placenta grows. It's unable to be accommodated in these areas other than the uterus. This can be a life-threatening emergency for the mom. Okay, supportive care and treat your signs and symptoms. You may have to treat her for shock, as she may have severe bleeding. Hypertensive disorders of pregnancy. We have preeclampsia, which is the non-convulsive state of toxemia. Preeclampsia was known at one time as toxemia, and some people may still refer to it as such. This is a progressive disorder that is usually characterized as mild or severe. Proteins can spill into the urine, and your patient may complain of headache, epigastric pain, or visual disturbances. Her blood pressure can be high, and the systolic rate or the systolic reading usually rises 30 millimeters of mercury than what is normal for mom. She'll have excessive weight gain, and there'll be a lot of edema noted. She may, like I said, with the protein spilling into the urine, she may notice a very strong smelling urine output. Complications of toxemia can include abruptio placenta, which we'll talk about a little bit later, stroke, renal failure, pulmonary embolism, and DIC. Once mom begins seizure activity from a preeclamptic or toxemic state, she is said to now be eclamptic. She is suffering from eclampsia. Okay, it includes seizure activity and can lead to coma. She will experience generalized tonic-clonic seizures. She may complain of visual disturbances and epigastric pain. Pain in the upper right quadrant often indicates an impending seizure in these situations. The risk of fetal mortality increases 10% with each seizure mom experiences. This is a true life-threatening emergency for both mom and baby. Placenta previa is going to be found later, usually later in pregnancy, and it is a major cause of third trimester bleeding. It occurs in approximately 250 births. There are 3 different types of placenta previa: total, partial, and marginal. The placenta usually is implanted at the top portion of the uterus and posteriorly, allowing for growth of the baby. As the fetus, or when the fetus changes positions in the uterus, the cervix will begin to efface or thin. Another word for thinning is effacing, and dilate. As this happens, the placenta is prematurely torn away from the lower part of the uterine wall. As a result, bleeding will occur, and it may be excessive because the placenta is so rich in blood. Okay? If bleeding is not associated with this, keep in mind that the uterus can hold an excessive amount of blood before it is presented externally. Bleeding in this situation is not associated with any abnormal uterine contraction nor is abdominal pain. Okay, some of the predisposing factors: if mom has had more than 2 deliveries, rapid cessation of pregnancy, so she got pregnant very close to her last delivery. If she is older than the age of 35, if she has a history of placenta previa, If she has a history of early vaginal bleeding in her pregnancy and bleeding immediately after intercourse are all predisposing factors for placenta previa. So let me recap that, and I'm going to put it in simple terms. So normally the placenta attaches itself to the uterine wall at the top portion and toward the back. With placenta previa, it's either attaches lower in the uterus, or as the baby grows and moves, it's pulled down further into the lower portion of the uterus. As the baby grows, it'll put pressure on the placenta, and mom may have painless vaginal bleeding. You normally see that type of vaginal bleeding in her third trimester. Sometimes after intercourse, she may complain of vaginal bleeding because of the pressure being put on the cervix from the opposite side. Okay. Assessment findings. Your hallmark sign is third trimester vaginal bleeding that is painless. I don't know why I'm bleeding. I'm not hurting at all. Have you had placenta previa before? Yes, with my last pregnancy. And that's probably what's going on now. The uterus is typically soft and non-tender on palpation. Bleeding in this situation may be bright, dark red, or even an intermediate color, somewhere in between. You want to assess mom for hypovolemic shock and treat her accordingly. Medical care, you want to treat her for shock and her signs and symptoms. Now, abruptio placenta is an abnormal separation of the placenta from the uterine wall prior to the birth of the baby. Okay, let's keep it simple. So when abruptio placenta happens, the uterus is, or the placenta, is detached from the uterine wall, and mom will experience painful bleeding, usually in her third trimester. There are two types, either complete or partial. So it either completely detaches from the uterine wall, or it'll partially detach from the uterine wall. Predisposing factors: hypertension, the use of cocaine and other drugs, preeclampsia, we talked about earlier. She's carrying twins or more. Previous abruptions, smoking, short umbilical cords, premature ruptures of the amniotic sac, and even diabetes. Okay, your assessment finding, you will note vaginal bleeding associated with a constant abdominal pain. The uterus contractions are usually present. By no means are they pleasant. Vaginal bleeding may be severe, minimal, or even absent, depending on the location of the fetus head. So if the fetus's head is blocking the cervical opening, there may not be bleeding. She will be in pain, however. Emergency medical care, you want to treat accordingly, treating her for shock, putting her on oxygen, raising her feet, and definitely covering her with a blanket. Uterine rupture. The uterine wall becomes extremely thin, especially around the cervix, and it can lead to spontaneous or traumatic rupture of the uterine wall, releasing the fetus into the abdominal cavity. Mortality rate to the mom from a ruptured uterus is usually 5 to 20%, but fetal mortality rate is usually over 50%. Okay, this type of injury of condition is going to require immediate surgery. Your assessment findings will include a history of previous uterine rupture or abdominal trauma. She may be carrying a large fetus. Maybe she has gestational diabetes, which we know is going to present with large babies, big babies. Maybe she's having more than 2 children, or she's had more than 2 children. She has a history of prior cesarean sections or uterine surgery. There may be tearing or a shearing sensation in the abdomen, and there is going to be constant and severe abdominal pain. Okay. She will show signs of shock. Vaginal bleeding is typically minor, but keep in mind it could be heavy as well. And you can feel the baby in the abdominal cavity outside of the uterus. Like you may actually feel fetal body parts that have escaped from the uterus. Emergency medical care, supportive care. Follow your general guidelines for emergency care of pre-delivery emergencies according to your protocols. Put her on oxygen. She needs to get to surgery. Okay. Treat her for shock if she presents in such a manner. Something called hypotensive, supine hypotensive syndrome typically happens in the 3rd trimester, and it's a complication that occurs when the weight of the fetus compresses the inferior vena cava when the patient is on her back. It reduces blood flow to the right atrium, which can decrease preload. Okay. When that happens, when preload is decreased, mom's going to be hypotensive. She will typically complain of dizziness or lightheadedness when she's laying on her back. In severe cases, she may experience a decrease in her blood pressure. She may also experience tachycardia. Her skin may be pale, cool, and clammy. Be sure to assess her for blood loss. And I'm not telling you you have to take a peek, but you question her, okay? Has there been any bleeding associated with this when you're feeling like this? Emergency care, you want to put her in a sitting position if she can tolerate that. If not, you can lie her on her left side, or you can even put her supine and elevate her right hip. And what happens when we do either of these things is takes the pressure of the baby off of that inferior vena cava. Okay. So this is going over the algorithm for antepartum emergency care. And you guys can read that as well as I can explain it to you. It's very, very straightforward. Let's talk about stages of delivery. Your first stage of delivery begins with the onset of regular contractions to the full dilation of the cervix. Okay. At this time, mom may tell you, yeah, I lost my mucus plug. I think my water broke. She may or may not be feeling contractions early on. Okay. She may complain of simply an aching back, or maybe, the bottom part of my belly is hurting. It feels like menstruation cramps. I've heard that before. Okay. But know that the first stage of labor begins with the onset of regular contractions and ends with the full dilation of the cervix. You want to evaluate your patient and transport if she is in fact having these contractions, if she's entering the first stage. But be aware that the first stage of labor can last for hours. Typically 8 to 10 hours, sometimes more. However, the more babies she's delivered, the shorter the first stage of labor can be. Okay, sometimes it'll still be a long process, but typically it's a lot shorter the more children she's delivered. The dilation stage ends when the contractions are regular in regular intervals, usually 3 to 4 minute intervals, and they lasting about 60 seconds each. She will feel very intense contractions. Okay. Sometimes moms think they're in active labor, but those contractions are not in regular intervals. This is what's known as false labor or Braxton Hicks contractions. Now, your book tells you they're painless and they're short in duration and they're irregular. Okay, and they can start as early as the 13th week. Well, I'm here to tell you that these are or can be painful. They will be irregular and they can start in your second trimester. It's the body's way of preparing itself for actual delivery. Okay. It's also thought that with Braxton Hicks contractions, it improves placental blood flow. These contractions cause no cervical dilation or effacement, and they do typically remain irregular. However, mom may mistake these as actual labor. You can't, in the field, we can't be absolutely sure whether it's true labor or Braxton Hicks. So we should encourage our patients to be transported to the hospital for further evaluation. The second stage of labor is the actual birth of the baby. Labor begins with the complete cervical dilation and ends with the delivery of the baby. During this stage, the infant is going to move through the vagina, the vaginal canal, and is born. Okay? Contractions are closer together and they're lasting a little bit longer, usually minute and a half, sometimes a little bit longer than that, and they're usually 2 or 3 minutes apart. Mom may tell you she feels the need to have a back. There may be bulging in the perineum. You may notice crowning at this point. Okay, if crowning is present or mom tells you I need to poop, then you need to be prepared because that baby is going to be delivered. As the baby moves down into the birth canal, mom's going to experience considerable pressure on her rectum simply because of the anatomical positions of these organs. She often complains that she's got to poop. As the infant's head appears at the opening of the birth canal, you may see crowning. You may see its head. The mother should be coached to push with each contraction. Okay. The shoulders, once the head is delivered, the shoulders and the rest of the body will quickly follow. Hopefully will quickly follow. Sometimes babies are too wide at the shoulders, so we may have to help them out a little bit. But typically that's not the case and they just come right on out. Best case scenario. Okay. The first delivery, the second stage typically lasts about an hour, 50 to 60 minutes or about an hour. The patient who has had more than one child, usually about 20 to 30 minutes. But remember, we can coach mom. We need to coach mom to push with each contraction. Okay? And the third stage of labor is what's known as the placental stage. Okay, the placenta should present itself after the baby is delivered. The average time for the placenta to deliver is 5 to 20 minutes. We're not going to tug or pull on the umbilical cord to speed the process up. We may or may not deliver the placenta in the field. Okay, it just depends on our transport time, so forth and so on. When the placenta is or has delivered, we want to collect it and place it into a plastic bag and into a red bag. This has to be transported with mom and delivered to the hospital, where they will further examine it and weigh it making sure that the entire placenta has been excreted or removed from the body. Okay. Sometimes the amniotic sac has not ruptured when mom is and baby is delivered still housed in the amniotic sac. This is the amniotic sac itself is a membrane surrounding the fetus. We know that fluid originates from fetal sources, urine and secretions, things of that nature, and fluid accumulates rapidly. There's going to be about 500 to 1,000 milliliters of amniotic fluid after about the 20th week of pregnancy. When the fetus delivers and it's still housed in the amniotic sac, we will have to rupture that sac for fetal delivery. And to do so, we would simply tear the sac away from the fetus. There will be a rupture of the membrane will produce a watery discharge. Make sure you have donned all of your proper PPE, gloves, goggles, face shield, gowns, because you don't want to get these body fluids in your mucous membranes. Again, if that sac hasn't been torn already, we will have to go ahead and tear it before baby delivers. Okay. You will notice if the amniotic sac has in fact ruptured when crowning is present. You'll see that sac or that film around the fetal head, and you'll be able to tell the difference. And so we would simply pinch and tear that sac away from the baby's head. Okay. When it comes to delivery, we know that babies are known as neonates. Okay. Once the baby, we know that crowning is present, we're pretty much there just to catch. Okay. You don't, what I want to emphasize here is that suctioning is not necessary unless there is meconium present. Okay. I'm going to say that again. We're not going to suction babies, neonates, unless there is meconium staining. And in doing so, we are going to suction the mouth first and then the nose as soon as the head presents. Meconium is a yellowish, brownish, greenish substance that indicates the baby was in somewhat of distress during labor and before delivery. Okay, we don't want to allow baby to inhale meconium into their lungs, because then that causes a whole array of other issues. If meconium staining is present, we would then, as soon as the head delivers, suction the mouth and then the nose. Okay, once that is done, baby is going to allow baby to continue to deliver. Shoulders will deliver hopefully easily, and then the rest of the baby will come out. Okay, it is imperative for us to dry and stimulate baby. Okay, keeping these babies warm is as important as an airway when they're first delivered. Okay, baby delivers, you want to keep that baby at the level of the vagina until the cord is cut. We're going to clamp the cord 6 to 9 inches from baby. Let's see, 6 to 9 inches from baby, and then 2 to 3 inches from the first clamp. Okay. Once the cord stops pulsating, we can then cut the cord. Okay. All the while we're stimulating baby. We want to warm them up and give them to mom. You definitely need to protect them from heat loss, and suction is necessary. I think I went ahead of my my slides. Let's go back to this one. Okay, so be sure to stimulate these babies. You want to tick them off. You want to make them mad. A crying baby is what we want. And usually when you're drying them and stuff, that usually makes them pretty teed off, if you will. Dry them really good, but remember, we have to keep them warm. As soon as they're dried, we need to wrap them up, put a little stockinette on their head. You can wrap them in a blanket or a towel, anything that's going to keep them warm that's not wet. Give them to mom. Skin to skin contact is optimal because it's going to allow mom's body heat to warm up baby. Okay. Repeat suctioning as necessary. You want to position the baby on his back with his head slightly extended. Remember, we don't want to hyperextend the neck because their little trachea is so short and so pliable. We may actually kink it when we're suctioning, and maybe even when we're providing oxygen. Keep them warm. Dry them off. Make them mad. Keep them warm. A minute after baby is delivered, we want to do an Abgor score. Okay, it's a test to basically give the baby a number, give the baby a score. You're going to perform this throughout your assessment. The first time it's done, it's 1 minute after birth, and then again at the 5-minute mark. A change in their Abgor score may improve or may indicate improvement, worsening, or no change at all. So what does the Abgor score assess? It assesses appearance. If the entire body is cyanotic or pale, the baby gets a 0. If the hands and feet are blue, but the core of the baby is pink or of their natural ethnic color, they get 1. If they have their natural color throughout their body, they get a 2. On to pulse. If they have no pulse, they get a 0. If they have a pulse rate less than 100, they're only getting 1 point. But if they have a pulse rate over 100, they're getting a 2. Look at their grimace. Look at their activity. Are they active? If they have no reflexive activity when we stimulate them, they get a 0. If they have some facial expression when we stimulate them, they get a 1. If they cough and sneeze and cry, and it's a good strong cry and they're really ticked off, they get a 2. Look at their activity level. If they are limp and there's no movement at all, they get a 0. But if they display some flexion without active movement, they kind of move a little bit, but not really, they get a 1. But if they're actively moving their arms and their legs, maybe even their little head, they get a 2. Move on to respirations. If they are not breathing, they get 0. If their breathing is slow or irregular and they have a really weak, barely even a cry, they get a 1. But if they're crying and they're crying loudly and strong, they get a 2. Okay? We want these babies to have 2s in all areas. And we can help them gain those 2s by drying them off and keeping them warm and stimulating them. Okay? So the guidelines to determine the significance of the score, if they scored 7 to 10, they should be active and vigorous. All we got to do is give them to mama, keep them warm. Okay? If they get a 4 to 6 on their Abgor score, they're moderately depressed. We need to continually stimulate them, and we may need to provide oxygen therapy. If they get a 0 to 3, they are severely depressed. And we need to provide extensive care, including oxygen. We may even be doing CPR and bagging these babies. Okay? So make these babies angry, get them stimulated. And the next slide shows you the chart for the ABGAR scoring system, and this is in your book as well. Okay. Most of the time, newborns, neonates require just basic care, but occasionally there are babies who are severely depressed. If their respiratory rate at birth is above 60, respiratory arrest or severe distress. If there are diminished breath sounds, their heart rate is above 180 or less than 100, or their pulse is weak, they are severely depressed. If there's obvious signs of trauma, okay, during the delivery process, expect your babies to be obviously depressed, severely depressed. If they have poor or absent skeletal muscle tone, if there's heavy meconium staining, maybe their little body is completely cyanotic, indicating poor peripheral perfusion, or there is a lack of poor response to stimulation, their ABGAR score is usually going to be less than 4. They are considered to be severely depressed. Okay, depressed and suppressed. So we need to act accordingly. When it comes to caring for neonates as well as pediatrics in general, we use what's known as the inverted triangle. The relative frequency of the need for resuscitative measures is often shown as in this inverted triangle. You'll see here we go from least aggressive to most aggressive. Okay, we don't start with medications and then work our way from there. We start with basic, keeping them warm and dry, suctioning them, tactile stimulation onto oxygen. Maybe we'll have to bag them or not. Maybe they'll have to be intubated, chest compressions, and then we get to medications, not the other way around. We want to dry, warm, and position. Suction as necessary. That's always the first thing you want to do, okay? Again, if their breathing is shallow or slow, maybe they're gasping or not breathing at all. If the heart rate is less than 100 and they remain cyanotic, we may need to bag these babies at a rate of 40 to 60 breaths per minute, okay? Compressions are going to be performed if their heart rate is less than 60, okay? And we're going to deliver 120 compressions in a minute. Their little hearts beat really fast and they breathe really fast when they are at this stage in their life. Sometimes mom will experience postpartum hemorrhaging, okay? Typically, she should lose about 500 milliliters of blood, but if she has a greater blood loss, we can help her. We can help control that bleeding by performing uterine fundal massages. Okay, remember I told you the fundus is the top of the uterus. Okay, between her belly button and suprapubic area is typically where you're going to find this after she delivers. In providing uterine fundal massages, you are going to, in a circular, firm, yet gentle, because this is painful for mom, in a circular motion, you're going to provide these fundal massages. Encourage mom to nurse the baby, because breastfeeding helps with bleeding control. It helps the uterus to contract, therefore helping control bleeding. Okay, so uterine fundal massages. And she won't like you when you're doing this because it is painful, but it has to be done. This is meconium staining. Okay, we talked about this a little bit earlier. Meconium staining may occur during a difficult labor when the fetus is in distress. It's caused by the fetus having a bowel movement in the amniotic fluid. It's a greenish or brownish yellow substance, and it indicates that the fetus experienced a hypoxic event. We don't want the fetus to, or the baby to, inhale this amniotic fluid. So like I told you before, as soon as the head presents, if meconium is recognized and noticed, you want to go ahead and suction the baby aggressively, okay, before they take their first breath. You will suction the infant's mouth and then nose as soon as it delivers. Don't wait for the whole baby to deliver, if at all possible. As soon as that head delivers, you want to be suctioning, okay? Don't stimulate the baby before you suction, because if you stimulate baby, it's going to cry. And when it cries, it's going to inhale all of that meconium into their lungs, and that can result in severe aspiration, pneumonia, and infection. Okay? Transport the baby as soon as possible along with mom when this occurs. Again, you want to maintain their airway and support ventilations as necessary throughout the transport. The nuchal cord. The nuchal cord is when the cord is wrapped around the baby's neck, head and neck, sometimes once, sometimes more than once, okay? Optimally, we want to try to get the cord from around the baby's head before delivery occurs, okay? In doing so, you would put 2 fingers around the cord itself and try to slip it over the baby's head before the baby delivers completely. Okay, prolapsed cord is when the cord presents before the baby. This is an intrapartum emergency, and it occurs during the period from the onset of labor to the actual delivery of the baby. After the amniotic sac ruptures, the umbilical cord, rather than the baby's head, may be the first presenting port in the vaginal opening. This is known as a prolapsed cord. In this situation, the pressure of the infant's head or the buttocks may compress the umbilical cord against the walls of the vagina and the bony pelvis. Pelvis. If this occurs, it can cut off the infant's supply of oxygenated blood, and this is a true emergency. The baby may not survive if that pressure is allowed to remain. Some of the predisposing factors would be prematurity, premature deliveries, multiple births, or premature rupture of the amniotic sac. In a situation like this, you want to keep the baby's head off of the umbilical cord. You would have mama elevate her hips, maybe with a pillow or a blanket or towels, put her on oxygen, keep mom warm, okay? You want to keep the baby's head away from the cord by inserting a couple of fingers into the vaginal opening, removing the baby's head from putting pressure on that umbilical cord. Don't attempt to push the cord back in, okay? If the cord is in fact out of the vaginal opening, you want to wrap it in a moist, sterile towel and transport mom to the hospital, continuing to keep pressure on the baby's head and off of the umbilical cord. If mom feels the need to, if she's in labor and she is contracting, instruct mom not to push. Do not push. Instead, have her pant. Okay. If you have to, you can put her in a knee to chest position, keeping pressure off of the cord. Um, you want to, again, you will transport mom with a gloved hand, uh, removing pressure from the umbilical cord. Okay. Again, do not try to push that cord back in. All right, breech birth. Breech birth is when anything other than the head is presenting first, usually the butt. Okay. A breech birth is a common abnormality of delivery where the butt or the lower extremities are the first to be delivered. This is a complication of delivery that when the head is not going to be delivered initially. If this occurs, insert your index and middle gloved fingers into the vagina. Oh, okay. So I'm sorry, I'm getting ahead of myself. So breech birth, you want to, hopefully mom won't, she may deliver, but hopefully not. Sometimes it's a partial breech, sometimes it's full breech. We can position mom with her butt at the edge of the bed, put her in a knee to chest position, okay, expanding the pelvis. That way, if she does have to deliver, it may not be as difficult on her. In a breech delivery, sometimes the head won't be able to deliver. If this occurs, insert your index and middle gloved fingers into the vagina, forming a V along the vaginal wall with the baby's nose and mouth between your fingers. Okay. If the baby's head can't deliver, if baby is coming head first but can't deliver, okay, you may have to do this. Breech deliveries are best performed in the hospital, obviously. If there is an incomplete breech, such as a foot presenting first, there's nothing we can do but get mom to the hospital. She is going to require surgery. All right. When there is a limb presentation, we never ever want to attempt delivery in the field. Now, best case scenario, baby is born face down. Okay, it makes it easier for mom and baby. In other situations, you may have a face presentation or a brow presentation. And it goes on to talk about chin, anterior, and posterior presentation. If this is the case and mom can't deliver and the head is first, but you're seeing the face, that's when you may have to do that two-finger V into the vaginal canal to keep around the baby's airway, to keep them, keep their airway open. Okay. All right. Enough about newborns, huh? Let's talk about some pediatrics. All right. So, pediatrics. Best case scenario, they look healthy. They're well perfused, no problems with breathing. But know that your assessment for these kids are going to be the same yet different because of their anatomical differences. Okay. So this kid has no trouble breathing, but look at these two little guys. Okay. So we're going to talk about respiratory distress and then on to failure. With a child in respiratory distress, there are some very telltale signs of their level or severity of difficulty breathing. With a child who is in simple respiratory distress, which is not simple at all, you'll notice their flared nostrils. Okay, the little nares will flare out. They will have some retractions present, and they will have some abnormal sounds, such as stridor or gurgling, and even wheezing. They will have abnormal positionings. They'll sit in a tripod position. They may keep their head up, their neck and their head up in what's called a sniffing position to help them get more air in more easily. These kids are going to refuse to lie down. With the kid in respiratory failure, again, they'll have the flared nostrils. They will have the retractions, the abnormal sounds, and abnormal positioning, just as those in respiratory distress. However, these kids are going to have some head bobbing. Trying to get air in. They're moving their head with when they're inhaling. Okay, they're going to be irritable and unconsolable. They may be getting tired and have that gazed appearance, that gazed look in their eye. They'll be listless or a decrease in their muscle tone. You may note cyanosis, pale or mottled skin. Okay. These are significant signs of respiratory failure, which can lead to respiratory arrest. In your respiratory arrest, they will have a decreased work of breathing. They're just getting tired. They're not going to continue breathing very long. Their breathing may be slow or apneic. That may be irregular or even gasping. They can be unresponsive or will become unresponsive shortly. They're listless. They have no muscle tone. They're limp. Their skin, again, is cyanotic, mottled, pale. And then their heart rate will be slower, weaker, and even absent. Okay. When a kid gets tired, they will tire really quickly. Okay. The number one cause for pediatric cardiac arrest is respiratory failure and arrest. So we fix that, we manage that, and we keep our kids from going into cardiac arrest, hopefully. Fever in children typically causes seizures. Okay. Fever of 104 to 105 is very concerning, regardless of the age. All right. Causes of high temperatures can include infections, heat exposure. Okay. The degree of the temperature is not always the greatest concern. Okay. It's the how quickly the temperature rises, the spike in the temperature. That is our biggest concern, because when that temperature spikes rapidly, our kids can have seizures. Okay. In an emergency situation like this, we need to lower their body temperature. How do we do that? Get all their clothes off of them down to their diaper or their underpants. Okay. We're not going to douse them in cold water or use alcohol, but we need to get them cooled off. You can put them on oxygen. Okay. If a child with a fever is cooled off too quickly, the brain is going to be overstimulated. So we don't want to cool them off too quickly, but at a steady rate. Okay. If they are allowed to cool off too quickly, again, the brain will be overstimulated and the child may seize. Seizures in children, the most common cause of seizure is fever, okay? But seizures can also be caused by epilepsy or head injuries, meningitis, oxygen deficiencies, overdoses, even electrolyte abnormalities, brain tumors, and hypoglycemia, okay? Some of the signs and symptoms are just that of any other seizure patient. Their arms and legs can become rigid. Their back may arch and their muscles may twerk or jerk in muscle spasms. Their eyes may roll back and become fixed. Breathing may become irregular or ineffective. They may lose bowel or bladder control. And we're going to treat these patients just like, or manage these patients just as we would any other seizure patient. You want to ensure their airway is open and be prepared to suction. You want to keep them from hurting themselves by moving any hazardous or hazards away from them. Okay. And when the seizure is complete and they're in a post-ictal state, we want to put them on oxygen. Okay. But be aware that fever is the most common cause of seizures in children. Cardiac arrest, you want to perform efficient CPR with minimal interruptions and use the AED for those who are over 1 years of age or older. Although cardiac arrest is not a respiratory problem per se, it's a very big concern because their respiratory status will deteriorate quickly. Almost all cardiac arrest in children result from airway obstructions or respiratory distress leading to failure and arrest. Okay? Be sure to be aggressive in your management of respiratory problems as well as shock, as they will progress quickly into cardiac arrest. You want to begin your chest compressions if their heart rate drops less than 60, okay? Less than 60. If the child is unresponsive and they're gasping or there are no respirations, you don't hear or feel any heart activity, there's no chest movement, they're cyanotic or pale, and they have an absent pulse, you know that this child is in cardiac arrest. Provide positive pressure ventilations with supplemental oxygen. Begin CPR as soon as possible and call for ALS backup. Okay? If ALS backup is not readily available or you don't work with an ALS on an ALS unit, get these kids to the hospital while continuing CPR. Geriatrics. All right, so we've started at birth. We've talked about kids. Now we're going to talk about our older generations. Just like kids, anatomical cysts or anatomical, there are anatomical differences in children. When it comes to the old people, it's important for us to realize that they have a lot of physiological changes, okay? Everything kind of starts to slow down and shut down. I'm not going to go into great detail, although I am going to cover this thoroughly, but it's up to you to read in your book because there are some things that I'm not going to cover in this discussion that you need to be aware of. So the human body changes with ages. Changes in cellular organ and systems functions are inevitable. We're going to get old, okay? Elderly patients make up a large percentage of EMS calls today because of their chronic or long-term injuries and illnesses. A lot of elderly patients have multiple diseases going on at the same time. CHF, COPD, diabetes, cardiovascular disease. They may have a multitude of medical conditions in which they take a multitude of medications for, okay? And we need to learn, we need to recognize these and know, what to expect when we are assessing and managing these patients. We're going to take it system by system. In the neurological system, your brain starts to get smaller. Your neurons, your nerve cells in your brain, listen to this, begin to die as early as our mid-20s. Okay? This causes slowing in our reflexes. The elderly have a hard time perceiving their body position, and it makes them unsteady on their feet. They're susceptible to falls. Okay? That is the number one cause of trauma in our geriatric population is falls. Their sight begins to diminish, and altered mental status is very common because of changes within their brain, their neurological system. In the cardiovascular system, stenosis may occur. Narrowing of the valve opening in the heart restricts blood flow through the heart. So the heart itself can't meet the demands of the body. The patient may begin to deteriorate. The valves in the heart can no longer seal as tightly as they once did, so their blood may be forced back through it, also known as regurgitation. This is more common on the left side of the heart with the bicuspid and mitral valves. When this occurs, when there is valve leakage, our patients you may notice pulmonary edema because of that regurgitation. They're more susceptible, the geriatric population are more susceptible to irregular heart rhythms, okay? Because there may be some electrical disturbances going on in there. The conduction system of their heart can begin to deteriorate with age, causing irregular rates and rhythms. They can develop arteriosclerosis, which is hardening of the arteries. When this happens, the heart can't pump blood as easily through the vessels, the arteries, as it once did, okay? Because those arteries don't give, they're stiffened, okay? So blood has a harder time going through. Cardiomyopathy, which is thickening of the heart walls. They can't hold as much blood, and therefore there's a decrease in the stroke volume. We know that less stroke volume means less cardiac output, okay? So the elderly patient's compensatory mechanism is less efficient during traumatic injury. So their blood pressure will drop a lot quicker than it did when they were younger if they were in the same traumatic situation. So what have we learned is that the heart grows weaker with age as the resistance of the arteries increase. When that happens, we experience hypertension. Abnormal heart rates and rhythms can become very common because of the deteriorating conduction system. With our respiratory system, the respiratory muscles lose their elasticity, and there's a decrease in the size and strength of the muscles of respirations. The rib cage becomes less pliable due to calcium buildup. So they may not be able to take a full inhalation and exhalation. So their inspiratory and expiratory phases may be a little bit longer than a younger adult, okay? So in saying that, their resting respiratory rate may be higher in the elderly. Their chemoreceptors in the aortic arch and the brainstem become less sensitive over time. So they can't determine or detect hypoxia. Even down to their nasal secretions. Our noses secrete less antibody substances into the mucus, so they become more susceptible to infections. Our immune systems our defense mechanisms are lessened, making us more at risk for infections as we get older. In our GI system, our taste buds begin to deteriorate. And that sucks, huh? So we may not enjoy food as much as we once did. Gum disease causes tooth loss, so now we got to wear dentures. The smooth muscles in the esophagus begin to decrease. Okay, they don't work like they once did. So now we have chronic heartburn. The liver size decreases, so it doesn't work as effectively as it once did. We know that the liver is a filtration system, okay? So it doesn't filter toxins and other chemicals that like it once did, as efficiently as it once did. Because it doesn't do that, it also doesn't metabolize certain medications, okay? There is a loss or slowing down of our gastrointestinal muscles. So constipation and bowel obstructions become very common in our geriatric population because the gastrointestinal muscles aren't able to move food through the system as rapidly as it once did. They may lose bowel control. They may lose urinary control. Okay. Our renal system, the kidneys become smaller, and there is a higher risk of drug toxicity because of that. Because our kidneys, along with our liver, don't metabolize certain drugs as quickly as it once did. Again, with the decrease in the GI absorption, it puts our geriatric population at a risk for unintentional overdoses. The integumentary system, the skin becomes thinner, so it's more prone to injury. Okay, a little bump may cause a skin tear because it's so thin. They can't regulate their body temperature as they once could, so therefore they are prone to environmental emergencies. Hypothermia, hyperthermia. They can't take the heat like they once did. They can't take the cold like they once did. Muscles and bones begin to lose minerals, making these geriatric patients more susceptible to fractures as well as the healing process. Okay. Once a geriatric patient becomes immobile, they will begin to decline very quickly. They may develop pressure ulcers. They can't fight infection as they once did. And this is before they're even, or this isn't even in conjunction with all the disease processes. Their immune system begins to decline, so they can't fight off disease. Their thermal regulator is not what it once was. So with your geriatric patients, it's important to remember they may not run fever when infection is present. Okay, so just because grandma is not running fever doesn't mean she's not septic or has some sort of infection. Gives you a whole lot to look forward to, huh? Yeah, I know, I'm feeling it. All right, so how do we assess these patients? Respectfully, okay, professionally, effectively. So when assessing your geriatric patient, allow them time to formulate their answers. Remember, their brain doesn't work like it once did. They still may be very sharp. Just because it doesn't work as quickly as it once did, doesn't mean that it stopped working completely. They still may be very sharp. It just might take them a little bit longer to formulate what they want to say. Don't confuse, guys. Don't confuse a slow response with alterations in their mental status. Explain to these patients what you're doing. Be respectful. A lot of our geriatrics are still very, very modest, okay? So if we just start touching them, that might, one, scare them because you are a stranger, and they're very modest and protective over their body, and they don't want us poking and prodding on us before we tell them what's going on. It's a respect thing. Talk to your patient. Don't assume just because they're older, they don't understand. Don't assume just because they're old, they can't hear. Yeah, I was put in my place very quickly many years ago when I approached a geriatric patient in a very loud voice. And he looks at me and he says, I'm old, but I'm not deaf. Okay. That was a very humbling experience for me. And don't stereotype them, guys. Ageism is a real thing. Don't just assume that just because they're old, they have dementia or an altered mental status. Get down, eye contact with them. Okay, don't tower above them. Get down to an eye level where you can speak directly to your patient. Okay, and talk to them, not just the family members or caregivers. Talk to them. So, patients with special challenges. Some of our patients, whether they be older or younger, have some sensory impairments. Okay, sensory impairments can affect people of any age, gender, or ethnicity. There is no bias when it comes to these. When it comes to hearing impairments, hearing impairment may be partial or it may be complete. When you are assessing a patient with a hearing impairment, place yourself where they can see you speaking. Okay, get down or remain at eye level with them, but position yourself where they can see you speaking. They can read lips really well. Okay, if you have to, you may need to utilize a family member or a caregiver to interpret what they're trying to tell us. They may understand sign language where we don't. Okay, so they can act as an interpreter in a situation like that. If that's not possible, then maybe we'll have our patient write what they want us to know. Okay. When it comes to speech impairments, there are a multitude of different speech impairments. The best thing I can tell you when it comes to that is to be patient. Allow these patients time to formulate their sentences. If they have a stuttering problem, they're going to get frustrated if you get frustrated. They're going to get frustrated regardless. But if we become impatient and cut them off when they're trying to say something, or not allow them to finish a sentence, or rushing them through it, they're going to become very agitated and maybe even not allow us to help them. Okay. Dysarthria is when a patient cannot produce words correctly. Okay. It can be caused by learning words incorrectly or from hearing impairments. Sometimes hearing impairments and speech impairments go hand in hand. Okay. Patients with visual impairments, such as glaucoma, maybe diabetic retinopathy, or maybe even a past traumatic injury. Sometimes these people use service animals. Okay. Be cautious, because that animal is at work. That animal is not there for you to play with. An animal is there for that patient. When we are dealing with patients with visual problems, we want to, again, get where they can see us, get where they can touch us, so because they can tell a whole lot by touch. Okay. Again, you may have to use family members or caregivers to help us in dealing with patients with impairments of all sorts. Developmental disabilities, Down syndrome. Autism has no look guys. You can't look at somebody and readily tell that they're autistic. Okay. Autism or autism spectrum disorder is a range of neurodevelopment conditions that are characterized by impaired social interaction, verbal and nonverbal communication, and is restrictive and repetitive behavior when it comes to Down syndrome. Autism doesn't have a look. I told you that. You can't tell just by looking at somebody if they have a developmental disorder all the time. Okay. With these patients, know that you need to make them feel comfortable. Move slowly. And when you're addressing them and when you're assessing them, move slowly. Ask them for their permission. Talk to them. Okay. Include them in the conversation you have with their caregiver. But ask them their permission. Seizures are very common with your autistic patients, but be aware that they may have a repetitive behavior disorder associated with their developmental disability, maybe rocking or pacing back and forth, maybe clapping or clicking their fingers. Okay, that's normal for them. If they become agitated, if they're startled, if they simply don't trust or like you, they don't know you, they can become violent and aggressive. Okay, so remember, your safety is always first, but know how to approach these patients. Avoid using medical terminology. Okay, use simple words. I call it talking in crayons. Okay, don't talk down to them, but talk to them on a level that they can relate to, they can understand. Get a good history and functional level from the caregivers. Keep in mind when we are dealing with these types of patients that bright lights and loud noises um, sometimes cause agitation and anxiousness and can set them off in violent or combative behavior. So and how are we going to know that? We're going to ask their caregiver. We're going to, find out as much as we can about them. If they can't answer us, then we need to turn to their caregiver or family members. Tracheostomy tubes. A tracheostomy is performed when it becomes necessary to open a new airway in a patient for either medical or traumatic conditions. Maybe patients with larynx cancer, or they've experienced penetrating trauma through the neck, and now they need a new airway. This is performed by tracheostomies. If it's permanent, okay, the opening is referred to as a stoma. Tracheostomy tubes sometimes become clogged with mucus, and sometimes they even become dislodged. You can suction with a soft catheter if necessary. Some patients on ventilators, they know their equipment. Just because they have a stoma or a tracheostomy doesn't mean they're not up and about, doesn't mean they're not mobile, doesn't mean they have an altered mental status or unresponsive. Sometimes they live full vital lives with the stoma or tracheostomy. If that's the case and they are on a ventilator, they know their equipment. Their caregivers know the equipment. Okay. Utilize these people, utilize the caregiver, those who are familiar with the equipment. Okay. Sometimes their vents or their ventilators will malfunction, and we may need to bag them until we can get their machinery corrected. Okay. Central IV catheters. Patients receive these in the hospital to receive medication into the central circulation of the body. These central lines can stay in for weeks or months at a time. It's so they don't have to be continually stuck in order to receive their medications or other uh, central circulation care, I guess is how I want to put it. A PICC line is peripherally inserted central line, and it's oftentimes inserted in the antecubital fossa. You'll see that like right here in their antecubital fossa, and they can continue to give medications through that. Sometimes you'll see them subclavicular, sometimes you'll see them in the jugular vein area, sometimes they're even femoral. Okay, but it's just so that they'll always have intravenous access. All right, the dialysis is designed to support loss function of the kidneys. It removes the buildup of toxins that occur when the patient's kidneys can no longer filter toxins anymore. These patients typically have high blood pressure or hypertension. Sometimes they have both. But understand that dialysis can be caused from traumatic situations as well. It's not just because of disease processes. It can also be associated with traumatic injuries. In dealing with dialysis patients, be mindful of their dialysis shunt. Don't ever take a blood pressure in the same extremity as the dialysis shunt because you can damage it. These shunts or grafts can be very easily, they're fragile. These things they sit right under the skin and they're very fragile. They can be easily dislodged. So be careful with those things. And you can see details about the difference between an AV shunt or an AV graft on page 1236 in your book. I believe it's under assessment or something like that. Okay. They're not always in an extremity. Sometimes they're on the chest. Sometimes they're in the femoral region. So just be aware of where they are and be cautious when dealing or handling these patients. Catheters, urinary catheters divert urine out of the bladder when there is incontinence or a dysfunction in the urinary tract. The Texas or condom catheter, these are for patients who can still expel urine on their own. And the indwelling catheters that we're most commonly familiar with are your Foley catheters. When dealing with a patient with a Foley catheter, make sure you put that catheter bag lower than the level of your patient. If you set it on your patient, or God forbid, you hang it above the patient, it's going to backflow into their urethra and so forth and so on. It can cause severe infections. So make sure that catheter bag is always lower than the level of your patient. Intraventricular shunt relieve intracranial pressure in cases of hydrocephalus. Hydrocephalus is caused by an increase or an excessive amount of cerebral spinal fluid. These intraventricular shunts drain that excessive CSF from the brain to a distal site, and you can see an example in this picture. Sometimes it's drained into the stomach. Sometimes it's drained into some other type of reservoir. This is most common in children, and common emergencies include occlusions that are serious due to the fact that if the ICP gets too high, the brain can herniate. So if these shunts get occluded, then it's not going to allow CSF to drain appropriately. And when that doesn't happen, pressure ICP in the brain is going to increase and can cause brain herniation. Shunts can also become infected. If this is the case, the patient will complain of headaches and have fever. When assessing this patient, You want to support any depressed or lost functions of their ABCs. There's not a whole lot we can do. There's really nothing we can do if these shunts do become occluded. We're just going to provide supportive care of their airway, breathing, and circulation. Hospice is care that is aimed to provide comfort to the terminally ill patient. Okay. Hospice aims to alleviate symptoms and focuses on pain management and comfort measures. Okay. These patients are usually older, but they can be any age. Okay. When it comes to dealing with hospice patients, remember it's not only the hospice patient, but it's their family as well. Try to be as empathetic and as you possibly can, knowing that they're going through a lot at that point, and they may not have much longer with their family members. So try to be as compassionate and empathetic as you can. The combat veteran, know that PTSD is very real. It is not something that's just made up, and it develops from high levels of stress from combat. Now, we have since learned that PTSD can be recognized in public service agents, fire, police, EMS, medical personnel. There's different areas of that can cause PTSD, child abuse, but we're going to concentrate on the combat veteran. So PTSD develops from high levels of stress. It isn't new, although it is more recognized today than any other time in history. It was once known as shell shock or combat neurosis. These patients sometimes suffer from drug or alcohol abuse, maybe sleep disturbances, anxiety, depression, and memory problems. Okay. PTSD patients, it doesn't mean that they have a weak mind. It means that they have experienced more than their mind may be able to let go of or handle. Okay. You need to know the differences between traumatic brain injuries and PTSD. Sometimes they can mimic, their signs and symptoms can mimic each other, and sometimes traumatic brain injury leads to PTSD. So a traumatic brain injury, know that it's an alteration in the brain function caused by an outside force, such as a concussion. Again, they are not mutually exclusive. I told you that sometimes TBIs, traumatic brain injuries, increase the likelihood of PTSD, but recognize the signs and symptoms of traumatic brain injury. Concussions, disorientation, confusion, trouble hearing, maybe blurred vision and dizziness. Repeated concussions can lead to permanent brain damage. Okay, get a good history on these patients. You're not going to know unless you ask, unless you assess. When assessing your PTSD patient or your traumatic brain injury patient, choose your words wisely. Okay, they relive what they have experienced on a regular basis. We don't need to ask them to relive that again. If we ask them, hey, have you ever killed anybody? That would be like somebody asking me, what's the worst call you've ever run? I don't want to relive that, and neither do they. Okay? Remember that certain sounds and smells, such as diesel fuel or maybe fireworks, can remind the patient of their traumatic event. My brother has PTSD, pretty significant. And like 4th of July, anytime there's a holiday or a situation where fireworks are going off, we have to be very careful. he won't participate in anything of that nature that includes such items, because it's just traumatic for him all over again. And you'll see that with a lot of your combat vets. Don't take it personally. Whatever they tell you, always protect yourself, because they can be reliving what they have experienced when we're called out there. So treat them with respect, and be aware of your surroundings. Let them know that you're there to help them and not judge them. And for talk to them, choosing your words carefully. Okay. And I think that's all that this session is going to cover. So I appreciate you guys listening to me. I hope I didn't bore you to death. Remember to read your chapters. This module 7 covers chapters 9 and 37 to 41. Some of the topics that were not covered in this review may be included in your exam, so make sure you read and prepare for that. Thank you for listening, and good luck in your studies.